Now, we make a lot of speeches around the CED and other places about how we must invest more in our future, and who can deny that? But we need desperately resources to do that. And I thought you'd be interested in the comparison between this increment of extra spending for health care versus all of the research and development investment in the United States. The health care cost differential is about 2.5 times what we spend in total for research and development. Now, Congress has recently discovered that there's a health care cost metastasis, and they've set a very interesting requirement that the budget deficit would have to be deficit neutral. As is always the case with Washington, stating the problem rhetorically is very different than actually solving it. Incidentally, even if they do achieve that objective of getting deficit neutrality, this leaves us with a melancholy question, which is, what are we going to do about the other $45 trillion of unfunded liabilities and $11 trillion of public debt? Now, it's easy to state some of the questions that I'm going to put before you that I'm sure the panel will elaborate on. It's easy to state them and very difficult to answer them. But basically, how much and how do we reduce these health care costs? And very important, how soon can we reduce these costs given the magnitude of the other deficits and debts? Now, why is it so difficult? Well, in my view, one of the reasons it's so difficult is that many of the large opportunities for cost savings are either A, quite structural and require very fundamental changes that could easily take considerable time to get implemented, and or B, they often confront cultural or political attitudes and expectations that will not only be very time-consuming but very difficult to reconcile. So this raises a question that I would like the panel to think about, among others. Where are the big cost savings opportunities that we could achieve, not in the long term, but in the short to medium term, given the magnitude of the short to medium term debt problem and deficit problem? When I was in the White House, we did have one genuine comedian, Henry Kissinger, and Bob will remember the day he went out on the press briefing. And Bob, you will recall that the White House Palace Guard at that time had sound bites and video bites and so forth. And whenever anybody stepped before the camera, they were supposed to have their sound bite well in mind. And Henry went out on the platform one day and says, "Does anybody have any questions for my answers?" Well, I just have questions about my questions today. Now, I don't have many answers, but I have several here I'd like to just put before you. We alone among the major developed countries have no health care budget. Instead of that, we have an open-ended kind of cost-plus budget, if we can call it that. Can we and how do we transition from what we now have to a real federal health care budget? And how do we confront the related political question, such as the budget requires the dreaded R word, rationing? It's as though everything in life isn't rationed. And when you are using, by most standards, excessive numbers of visits and tests and procedures, only in America can we think that we're going to give up some major health care procedures that might have some benefits. In other words, it runs into our cultural view these days that sacrifice is not only politically incorrect, it's politically terminal. And the idea that we'd have to give up something to solve a problem is not an idea that comes readily to our lips. Secondly, there are inexplicable and huge variations in costs in healthcare that would never be tolerated in corporate life between one region and another. For example, we have regions that have 6 times the back operations and 6 times the prostate removals as in other regions. Now, I know we have blue states and red states, but I had not realized until I saw these that we have bad prostate states and bad back states. There was a New Yorker article recently that was one of those seminal articles that changes the dialogue. I'd urge you to read it, on a county in Texas. I believe it was called McGowan, Texas. And this reporter does a brilliant job of trying to explain why the McGowan County, that is identical to many, many others in terms of demographics and health, spends twice as much Medicare per person as do these other counties. Now, obviously, we have a lot of what you might call worst practices in the way we distribute health care in this country. Yet we don't yet have the best practices outlined that would indeed improve health care at lower costs. And incidentally, not only do I ask you, how do we prepare these best practices, but what would be the answer to the political charge that we insist on using best practices, we're practicing some form of socialized medicine? Third question I would put before you, we have perverse incentives in the Medicare system, payment system, whereby the Medicare consumer has little or no motivation to reduce costs since it is considered free, and since the payment system is on a per visit, per test, or per procedure basis. In other words, the basis of the payment system is not value, it is volume. And of course, the providers understand that. The more they do, the more they get paid. Fourth, we have an open-ended tax subsidy whereby health expenditures are tax deductible to the corporation and tax-free to the employee costs. And along with some other health subsidies, they amount to about $260 billion a year. How can we best reform this perverse incentive that tends to minimize our sensitivity to cost differences in health care? At the very least, for example, should we CED fat cats have unlimited tax-free benefits? Fifth, there's some reason to believe that the so-called integrated health care system, or some form of clinic, is a system that both improves health outcomes and reduces costs, along with a full sharing of patient information on an integrated basis. I would ask the group how, however, and the CED, does this integrated care system, which requires a very different payment system, get implemented? Because it requires typically some kind of clinic or integrated healthcare unit, which the majority of the communities do not have. And finally, we would have to confront the argument that the patients don't get their choice of all of their doctors if you follow this approach. Finally, medicine spends 25% to a third in the last year of life, Medicare does, and much of this is an heroic intervention that is not only very costly, but often only prolongs life, but not the quality of life. The Terry Schiavo case illustrates the complexities that are raised here. So in the context of a country that is facing some of these kind of unsustainables, I was drawn to the comment by Tom Friedman about those of us in business, in which he said we were MIAs, we were missing in action. It seems to me the CED and its membership is ideally situated to make the desperately needed contribution to answering these and other questions about our out-of-control healthcare costs. And finally, as Chuck mentioned, I have the dubious distinction of being the longest sitting trustee in the history of the CED, but he was too much of a gentleman to say I was probably the oldest member as well. So it's been a great privilege being a member, and I commend the CED for what it's doing. Thank you very much.